Hello dear student, once again I am Dr. Smita Pakmade from NKP Savvy Institute of Medical Sciences. Welcome you all on second lecture of mineral metabolism. It is rightly said that none can destroy iron but its own rust can. So none can destroy a person but its own mindset can. So let's change our mindset, follow this distant learning and maintain social distancing. So here we are going to start with our second lecture, which is essential trace element, and here we are covering iron and copper. Just like in previous lecture we covered calcium and phosphorus, which were interrelated. Now in this lecture we are covering iron and copper, and these are also interrelated. So if you have a glance, you can see the maximum questions are asked on the absorption and functions of iron, that is short note mostly, and even you can get a case on iron deficiency anemia. For the copper, most of the time the functions of copper has been asked, and even defect in Wilson disease is most of the time asked, and you can get a case on Wilson disease too. So today's learning objective of today's lecture is, for iron we are going to study its function, sources and RDA, then factors affecting absorption of iron, regulation and absorption of iron, and this is manifestation of iron metabolism. In copper, we'll again study distribution and its function, sources, RDA, its biochemical functions of copper, and this is manifestation of copper. So let's start with our iron first. As we all know that iron contained in our body is 3 to 5 gram, which is very less, but iron is maintained in our body. Our body tries to utilize and reutilize body, and there is no way of excretion of iron like other compound has. So we this 3 to 5 gram of iron, which performs different functions of the body. Out of that, 75% of iron is present in the blood, mostly in the RBC. 20% of iron is present in liver, bone marrow, and 5% you will find in the muscle in the form of myoglobin. Iron is it has different functions in our body, and its daily requirement is also, like, on an average Indian diet contains 20 milligram of iron, but as our most of the diet is vegetarian, so that's why ultimately 1 to 2 milligram is absorbed in our body. But according to ICMR, our daily requirement is, like, for adult man it should be a 10 milligram per day. Uh, in menstruating women, as they are losing iron per day, so that's why requirement is high, that is 80 milligram per day. The infants are mostly dependent on mother's iron store. That's why the iron requirement increases high in pregnancy and lactation. You can say it is a 4 times of the normal, that is 40 milligram per day. Even in children between 13 to 15 years, they are growing very fast, so iron requirement is 30 milligram per day. So let's see first what are the iron containing protein or different forms in which iron exists in our body. So these are the 3 forms. Most of the iron present in the heme form. Then second is ferrous sulfur complex, and some non-heme iron protein. So heme, as we all know, that hemoglobin and myoglobin, which are responsible for the oxygen and carbon dioxide transport. Then even cytochrome, like cytochrome P450, or the cytochromes of electron transport chain, they contain heme as a iron. Then enzymes like tryptophan pyrrolase, catalase, peroxidase, they also contain heme. Now iron sulfur complex is the complex number 3 of electron transport chain. It is an example. Then enzymes like succinate dehydrogenase and xanthine oxidase, they are also the example of iron sulfur complex. Now the transport protein of iron, like pyridine, transferrin, hemosiderin, they contain iron in non-heme form. Now let's see what are the functions of iron. As we all know that it is hemoglobin and myoglobin, they are important because they transport oxygen and carbon dioxide in our body. Then cytochromes, which are present in electron transport chain, helps in the transfer of reducing equivalent. as well as cytochrome P450 is an example as it takes part in the detoxification process. Then peroxidase is an enzyme which is present in lysosome, and this enzyme catalyzes phagocytosis of bacteria by neutrophil. That's why iron is also responsible for immunocompetence of the body. Now this diagram or picture is easily is showing that major sources of iron is like a non-vegetarian diet, and the organ meat is a rich source of diet. But you will be surprised that the iron content in green leafy vegetable is high as compared to this non-vegetarian diet. But as it contains more amount of oxalate and phytate, the absorption of iron from vegetarian diet is less. Hence, still organ meat is a rich source. Out of this, liver, heart and kidney is the richest one. Then good sources, you can see leafy vegetables like spinach, then pulses, cereal, jaggery, fish, apples and dried fruits. These are the good sources. Now poor sources are milk, wheat and polished rice. The one glass of milk with your meal can reduce iron absorption to large extent. Now, absorption of iron starts in the duodenum, upper duodenum, and proximal jejunum. Now, there are two concepts you should know before you we go for the absorption of iron. So, there are two forms of the iron present in our body. It is the oxidized form, that is a ferric form, and another one is a reduced form, that is a ferrous form. Now, this ferric iron can be converted into ferrous form with help of enzyme ferroreductase. Now this ferrous form is a divalent atom, and this is the only transport form, and this ferrous ion can enter from one chamber to other. And when this transport form, that is ferrous form, can be converted into ferric form, that is a ferrooxidase, or which is also, this enzyme is also known as a ceruloplasmin. So this ferric form is a storage form. So whenever iron is stored in the form of like ferritin or hemosiderin, it will be always stored in the ferric form, and whenever it is transported, it will be transported in the ferrous form. Why? We will see later on. So before going to the mechanism of absorption, let's see first what are the factors which affect absorption of iron. So factors which increases absorption of iron is hydrochloric acid, then reducing substances like ascorbic acid, cysteine and sulfhydryl group of protein. We see how this happens. So here we can see that most of the time iron is present in bound form with the organic acid and the protein. So this HCl from stomach, it frees this iron from the bound form, and this ferric iron is further reduced by reducing substances like vitamin C and cysteine. So here you can see this is how it is helpful. But remember, the iron deficiency anemia, or the disorder where iron content of body is low, this rate of absorption of iron increases, and it may increase up to 10 times. Now let's see what are the factors which decreases absorption of iron. So like phytic acid, which is present in cereal, or oxalic acid, which are present in vegetable, and even presence of phosphate, this compound reduces iron absorption by forming insoluble salt. Alkaline pH also decreases iron absorption. In malabsorption disorder, there are free fatty acid, and this free fatty acid forms insoluble soap with the iron, and that's why reduces its absorption. Total and partial gastrectomy reduces the area for absorption of iron, and hence it is a factor which reduces iron absorption. Now friends, this is very important slide. Most of the time questions are asked on this slide, and here we are going to study the mechanism of absorption of iron. Now you can see there are three diagrams. The first rectangle, it shows GIT lumen. Then this is a free form which shows the mucosal cell, and third, it is a cylinder which shows the blood. Now let's see how the absorption of iron start. So we can see in the stomach or in GI lumen of the GIT, this the ferric form which is bound with the organic acid or protein in the diet, it is freed by hydrochloric acid to ferric form, and this ferric form is further reduced by vitamin C or glutathione or cysteine of the protein to the ferrous form. As we all know, this ferrous form can be transported. Now, why only ferrous form can be transported? So here is the answer. So there is the carrier protein, which is known as a divalent metal transporter. This protein will transport this ferrous ion from this GIT lumen to the enterocyte. So here you can see this presence of divalent metal transporter. This acts as a first level of regulation of absorption of iron, and its activity of this protein also depend on the ferritin content of the cell. So if the ferritin content of mucosal cell is high, this will reduce the synthesis of this divalent metal transporter, and as this transporter will be less, the absorption of iron will be less at this place. So this is the first point of regulation of iron absorption, and it depending on the presence of ferritin. Okay. Now let's move to the next level, that is the mucosal cell. So once this ferrous ion enter in the mucosal cell, it is converted into ferric form. It is oxidized by the ferrooxidase, and this this ferric form, it gets attached with the apoferritin to form the ferritin. Now this ferritin is again the temporary storage form of iron in the mucosal cell. This ferritin holds iron in the mucosal cell, and as we all know that the every day 30% of this mucosal cells are desquamated. So most of the time this ferritin is also lost in the feces with through this desquamating cells. Now this ferritin can release its iron to ferrous form with help of enzyme ferrireductase. But this conversion of this ferric ion into ferrous form, it depends on the presence of unsaturated transferrin molecule present in the blood. So if unsaturated transferrin is present, then only this ferritin will be released from this mucosal cell and it is transported to blood. Now let's see how it is transported. So ferrous ion thus released from the ferritin, it is again transported with help of one carrier protein, and this is known as ferroportin. So ferroportin is again it is controlled by one of the protein molecule or called peptide molecule, which is secreted from the liver, and that is known as hepcidin. So this hepcidin molecule is always present and synthesized by the liver, and this has a negative effect on the concentration of ferroprotein. So it is hepcidin always inhibits ferroprotein, and thereby it regulates the absorption of iron from mucosal cell to the blood. In case of the chronic condition where there is a decrease in the iron stored, like in case of anemia, hypoxia or hemorrhages, so this hepcidin concentration reduces, and thereby this ferroprotein activity of ferroprotein also increases, and then it increases the rate of absorption of iron from mucosal cell to the blood. So this is known as the mucosal block theory of regulation of iron absorption. Remember friends, the iron absorption is the iron metabolism or the concentration of iron in the blood is regulated only at the level of absorption. You can compare this with other mineral. Most of the mineral, they are excreted through the urine, but there is no way of excretion of iron in the urine. Hence our body tries to maintain iron level by regulating at the level of absorption. So that this is the mucosal block theory for the regulation of iron absorption. Now let's see what happened to the ferrous iron once it entered in the blood. It is again converted into ferric iron with help of enzyme ferrooxidase, which is also known as a ceruloplasmin. Now this ferric iron it binds with the apotransferrin molecule and it converts into transferrin. Now this transferrin is a transport protein which transfer iron in the blood. So each transferrin molecule can bind with the two molecule of iron, and this concentration of plasma transferrin is known as a total iron binding capacity. And in case of iron deficiency, this total iron binding capacity uh, increases much more. Even it can be 10 times of the normal. So this is big. So you can see how it is controlled. Now, how this transferrin helps to utilization of iron at different form. So here you can see the plasma transferrin. It binds to the two molecule of iron. Now this transferrin transfers this iron molecule to the distant organ, like it can be utilized in the RBC and bone marrow, and it is converted into heme, and it is utilized for the synthesis of hemoglobin, even myoglobin and cytoplasm. While in some few organs like liver, spleen and bone marrow, this transferrin is stored in the form of ferritin, and this ferritin can be converted into hemosiderin. So what is the total iron binding capacity? We have seen that transferrin is a glycoprotein molecule. So one molecule of transferrin, it combines with two atom of ferric iron. So normal total iron binding capacity, which is present in plasma, is around 250 to 400 milligram of iron per dl, and most of the time, usually in normal condition, only 1/3 of transferrin is saturated. But this saturation increase high, so TIBC is grossly increased in case of iron deficiency anemia. So let's see how iron is stored in the permanent form. So iron storage can occur in two type of protein, that is a ferritin and hemosiderin. So ferritin is stored in liver, spleen and bone marrow. Now this apoferritin is a huge molecule which has 24 subunits, and it can take up 4,500 of iron atoms to become the ferritin. So by weight, ferritin contains 25% of iron, and in iron toxicity, ferritin is increased and it is seen in plasma. Now, hemosiderin is another protein which contains 35% of iron by its weight, and it accumulates in the liver, spleen, and whenever there is excess demand of iron. Iron is also known as one-way compound. We have already discussed that once entered in the body, it cannot be excreted. So it acts in closed circuit. It is utilized, reutilized, and not excreted in the urine. And less than 1 milligram per day is excreted through the bile, salt, and sweat. So that's why it is known as iron is a one-way compound, and it's get deposited in the body in the form of hemosiderin. Iron is lost, major loss is through the feces, through the disformated epithelial cell. But as this iron which is lost, it is not absorbed one, so it does not changes the iron store of the body. But in menstruating women, it is if the iron is lost by 20 up to 25 to 30 milligram per day. Even few amount of iron is lost through the skin. So these are the ways by which iron is lost, but which is very minimal. So how iron is reutilized? We have seen even after hemolysis how iron is reutilized. So in case of you know that normal lifespan of RBC is 120 days, and after this RBC will lyse. So once this RBC is lyse, this hemoglobin combines with the protein which is known as a haptoglobin, and this hemoglobin the life of takes 5 days. But once this haptoglobin combines with hemoglobin, the life of this complex is only 90 hours. But this haptoglobin helps in the rapid clearing of hemoglobin from the cells, and this hemoglobin haptoglobin complex is taken by Kupffer cells and iron is reutilized there. On the second stage, you can see this globin is, once globin is removed, the heme is formed. So there is another protein which is known as a hemopexin. So heme hemopexin complex is taken by hepatocyte, and again iron is reutilized here. Now once heme is reduced, you can, this porphyrin ring is opened and there is formation of bilirubin. So iron which is released at this time, it is again binds with transferrin molecule, and there is formation of iron transferrin complex, and this transferrin acts as a storage protein. Now why I am telling you this, why iron is reutilized? Because you can see the haptoglobin and hemopexin, this protein may get lost in renal conditions, and that's why in renal disorders also we get iron deficiency anemia. So here you can see the renal insufficiency leads to iron deficiency due to loss of haptoglobin, hemopexin, and deficiency in erythropoietin. So this is how iron is reutilized. Now let's come to the disorder of iron. First of it is the iron deficiency anemia. This iron deficiency anemia is the most common nutritional disorder. Around 30% of world population is suffering from this iron deficiency anemia. Out of this, 85% pregnant women are victim of this iron deficiency anemia, and it is responsible for 15% of maternal death. In children, the irreversible impairment in the learning ability occurs if they are suffering from iron deficiency anemia from very young age. So what are the causes of iron deficiency anemia? So most common is the hookworm infestation. Hookworm infestation is very common, and hookworm, they absorb iron from the intestinal cell, and that leads to the loss of iron. Iron deficiency in diet, which leads to the nutritional anemia. Even repeated pregnancy, every pregnancy reduces iron store by 1 gram per delivery. And chronic blood loss, like in case of piles, uterine hemorrhages. Even renal defect, like loss in urine, that loss of haptoglobin and hemopexin may also reduces reutilization of iron, and thereby iron deficiency occurs in renal defect also. In subtotal gastrectomy and achlorhydria, there is a lack of absorption of iron, and which leads to the anemia. Now let's see what are the symptoms of iron deficiency anemia. So you can see in mild cases, you can point out the iron deficiency by seeing nail. So this is known as a koilonychia. This is like a spoon effect of the nails. You can see there is a central depression, and which is known as a koilonychia. It starts as a platynychia and then progresses to the koilonychia. Then if we examine patient, the peripheral smear will show microcytic hypochromic anemia. So here you can see this is the normal red blood cell. Now in iron deficiency anemia, the red cell size also goes down, and this color also decreases. So this is a microcytic hypochromic anemia. Most of the time hemoglobin is less than 12, and it is mostly it manifests when it goes less than 10 milligram per dl. Patients are mostly apathic, sluggish, and they don't feel fresh. They are not enthusiastic. Now, even because of this hypochromic anemia, there is a gastric epithelium undergoes atrophy, and this atrophy of gastric epithelium again leads to achlorhydria. And you know, STL is, it increases iron absorption. So because of achlorhydria, the iron absorption is reduced, and there is decrease in absorption of iron. So in chronic deficiency, in a chronic iron deficiency anemia, there will be impaired attention, then irritability, loss of memory, and poor school performance in case of children. So how to treat it? most of the time 100 milligram of iron plus 500 microgram of folic acid is given to every pregnant woman, and this supplementation is very necessary in uh, last trimester. In last trimester, you can see the infant in last trimester, whatever the infant draws iron stores from the mother's iron stores, and if and in first 3 months of the life, as the infants are fed with the breast milk only, there is no source of iron in their body. So whatever they get in last trimester from mother's blood serve as a reservoir of the iron for in their infant life also. So total is the 20 milligram of iron with in case of children, if it's a deficiency, it leads to the 20 milligram of iron, and 100 milligram, 100 microgram of folic acid is given in case of children. Now, iron toxicity may occur when the iron supplementation is more than 100 milligram of iron, and it is manifested in the form of hemosiderosis, increased accumulation of hemosiderin. Now, hemosiderin, they are golden brown granule, and they deposited on the spleen and liver. And these complexes are actually, these golden brown granules are the complexes of partially denatured ferritin, which contain 25% of iron. Now let's see what are the types of hemosiderosis. So this is a primary hemosiderosis and secondary hemosiderosis. In primary hemosiderosis, there is an abnormality of the gene on chromosome 6, and it increases absorption of iron, and this excess of iron is deposited in the organ. While secondary hemosiderosis is because of the repeated blood transfusion, like patient with hemophilia or thalassemia, they receive blood transfusion repeatedly, and this iron gets deposited in the form of hemosiderin. Even second example is a Bantu tribe in Africa. They cook their milk in the iron vessel, and apart from that they have the corn as a staple diet. Now this corn has low content of phosphorus. So low content of phosphorus, cooking meal in the iron, it increases iron content of food very much, and that's why such this Bantu tribe of Africa suffers from the same secondary hemosiderosis. Now, apart from hemosiderosis, there is one more disorder which is known as a hemochromatosis. This hemochromatosis, there is a direct iron deposition in the tissue. So you can see that because of this iron deposition, the liver gets dysfunctioning, and this is known as a cirrhosis of liver. In even the accumulation of this iron in pancreas leads to the diabetes mellitus, and on skin you can see the yellow-brown skin pigmentation, and that's why this is known as a bronze diabetes, which is the hemochromatosis. Now, treatment for this bronze diabetes is repeated phlebotomy and given despiroxamine. This despiroxamine is the iron chelating agent which removes iron from the blood. So this was about the iron. Now let's move to the another essential trace element, that is a copper. We have seen the role of ceruloplasmin in the absorption of iron. So this is ferrooxidase, or ceruloplasmin is same, and that is again the ceruloplasmin is a copper containing protein. So this copper has a role in the absorption of iron too. So let's study this copper molecule. Now copper content again is 100 milligram in our body. Out of this, 95% is present in our bases in the form of colorless pigment that is known as erythrocuprine, and rest of this copper is present as ceruloplasmin in plasma, which acts as a serum ferrooxidase. Now in plasma, out of 100 to 200 milligram per dl which is present, 95% of plasma copper is in the form of ceruloplasmin, while 5% is only bound with the albumin. Now let's see what is the RDA. Recommended daily allowances goes up to 1.5 to 3 milligram per day, and in sources it is a cereal, nuts, meat, liver and kidney, and egg yolk. and green leafy vegetables. So mostly the even sources are same as per the iron. Then again, milk is a poor source. Now absorption is from the duodenum, and here there is very important is metallothionein. This metallothionein is a protein which facilitates the uh, absorption of the copper. Now let's see what are the biochemical functions of copper. The important function of the copper is it is an essential constituent of enzyme. So enzymes like tyrosinase, uricase, catalase, the cytochrome oxidase, monoamine oxidase, superoxide dismutase, ascorbic acid oxidase, and phenol oxidase. So tyrosine is present in all this. The copper is present in all this enzyme. Then few important enzymes like ALA synthesis, a regulatory enzyme of hemoglobin synthesis. It also contains copper. Then copper is integral part of lysyl oxidase. Now lysyl oxidase enzyme is important in the cross-linking of collagen and elastin. So it is lysyl. It also depends on the copper. One more ceruloplasmin, which is also known as ferroxidase. It converts ferrous form into ferric form, and it is an important part of transferrin, which is transported in the plasma. Now tyrosinase is one of the enzyme which again which activity of which is dependent on copper. Hence it is a synthesis, it is responsible for synthesis of melanin and phospholipid, and even it is responsible for the formation of bones and nervous system, which is the melanin is developed. So what are the biochemical functions of copper? So first is it helps in the iron absorption and incorporation in the hemoglobin. That is a function of ferroxidase ceruloplasmin. Even it acts as a cofactor for vitamin C in hydroxylation reaction. And it as a component of copper containing non-enzymatic protein like hepatocuprin, cerebrocuprin, and hemocuprin. Now let's see what is the deficiency disorder of copper. So as it is also the anemia, but it is a microcytic normochromic anemia as iron content is proper. So that's why only cell size of RBC is reduced, but its pigmentation is proper. If not, if iron deficiency is also associated with it, then it will become microcytic hypochromic anemia. Now, because of, as we know that the presence of iron in lysyl oxidase, when the deficiency of copper, it will lead to the defective collagen, weakened collagen. That's why it will lead to the weakening of wall of major vessels. Even it leads to the fragility of arteries. Even same thing happens, the collagen is not proper in bone. So it leads to demineralization of bone, the demyelination of neural tissue and myocardial fibrosis. Then hypopigmentation, it also results in hypopigmentation like tyrosinase and graying of hair. Now we will discuss two disorders of copper metabolism. So this is the first disease which is known as a Menkes disease. Actually, this Menkes disease is because of deficiency of copper binding ATPase. What happened here? You can see copper is absorbed from the intestine, but it is bound to metallothionein. So it is though whatever the iron absorbed, it is excreted in the urine, but it cannot be utilized by the brain, skin, or bone. So there is a deficiency of copper in this organ, and it is represented in the form of hypopigmented and rough of copper. So what is a Menkes disease? It is an X-linked disorder. Copper is absorbed by intestine but cannot be transported to the blood. So absence of intracellular copper binding ATPase is the pathology, and copper may be trapped in the metallothionein in intestinal cell, and it is not mobilized to other tissue. So signs and symptoms, it is a decreased copper in the plasma and urine, and it also leads to the anemia, which is a normocytic normochromic. And apart from this, there is a deep pigmentation of hair. The hairs are kinky, twisted, and brittle hair. And this is because of copper catalyzed SS bond formation is reduced. That's why they are kinked and twisted. As as there is reduction in the melanin synthesis and other neurotransmitters, it leads to the seizure and mental retardation. Now let's move on to the last disease of deficient copper metabolism, and this is a Wilson's disease. If you can see, the genetic abnormality is similar to the Menkes disease, but there is little difference. So you can see the gene is again defective gene here is the ATP7A gene. In Menkes disease, it was defective gene was ATP7B gene. So it is the same gene with different variation, and even the enzyme is also copper binding ATP is also reduced. So what happened here? It is again autosomal recessive disorder, and the chances is into 1 into 50,000 childbirth. Now, because of this defective of copper binding ATPase, there is decrease in the excretion of copper through the intestine from the pipe. So you can see the liver cell cannot excrete, cannot leave copper because of our deficiency of this copper binding ATPase. So there is a decreased excretion of copper through the intestine from the bile. Then there is increased absorption of copper in the kidney, and even the hepatic incorporation of copper into ceruloplasmin, means the synthesis of ceruloplasmin in the copper from the copper is also reduced. So what happens? This free copper, which is not utilized or not excreted, this is accumulated in the organ. So which organs they are? It is accumulated. It can accumulate in the liver, and this is known as hepatic cirrhosis. Then even it accumulates in the brain, and it leads to the brain necrosis. And even in renal, it decreases absorption of the amino acid, then glucose, peptides, and hemoglobin. And the difference, that's why it is this Wilson disease is also known as hepatolenticular degeneration. Why? Because it affects this majority two organs, liver and brain. So what are the symptoms of Wilson disease? You can see this is in the liver we get hepatomegaly, jaundice, acute hepatitis, fulminant hepatic failure, and portal hypertension. While in bone, because of weakening of collagen, there's arthritis or the rickets, like the going of wet bearing bones. Then heme leads to increased hemolysis because of deficiency of elastase. In central nervous system, it leads to deterioration of school performance, then behavioral changes in coordination, that is handwriting deterioration, resting and intention tremor, dystonia, dysarthria, then excessive salivation and mass-like faces. In eye, you can see there is a brown color ring around the iris. In actual, it will be seen like this greenish brown color ring around the iris, and this is known as the KY ring or a Kaiser-Fisher ring, which is a characteristic of Wilson disease. Now, treatment. This is a fatal disease, and the treatment is like you can give diet low in the copper. Even penicillamine is used as a copper chelating agent, and this chelates copper and it increases its excretion through the urine. So, what are the signs of copper toxicity apart from the Wilson disease? So, copper toxicity can happen where there is excess of intake of copper. So, it may lead to diarrhea. Saliva may be a bluish blue green. Then it will lead to increased hemolysis, increased hemoglobin urea, protein urea, and kidney failure. Now here this is a case study we can learn. So this is a 13-year-old boy reported with the jaundice, fatigue, muscle stiffness, tremor, and behavioral changes. Now examination revealed an enlarged liver and spleen, and this is the Kaiser-Fisher ring is noted. So and copper. So we will continue in the next class. And if you think that this video is important, it has helped you, so please hit the like button. Thank you.